Welcome to another veterinary high performance how-to guide. Today, how to decide which horses need surgery of the back. My name is Patrick Pollock and I am a specialist in large animal and equine surgery. As with all of the veterinary high performance how-to guides, we are encouraging sharing of information about clinical problems affecting horses and other large animals. We are delighted to hear about the cases that you're dealing with wherever you are in the world. And if you need help or wish to discuss a case, please don't hesitate to reach out at any time. The decision for back surgery in the horse is complicated, and diagnosis of problems related to the back is an extensive topic and beyond the scope of this how-to guide. When we're presented with an animal that we believe has back pain, we'll see a range of clinical signs, often related to avoidance behaviour, animals that have poor performance, that have lameness, that have pain on palpation of their back, sometimes quite exaggerated responses to saddling or riding, and these clinical signs can be either very subtle or really very severe. We've got lots of excellent imaging modalities in equine surgery which we can use to examine the back, and we'll look at those in just a moment. The use of local anaesthesia has been discussed to help us with diagnosis of back pain in the horse. And in many cases, we may use response to treatment to help us decide whether or not these animals are good candidates for surgery. In many cases, animals will respond to conservative management, and we'll talk about that in just a moment or two. And it may be that that response over time becomes less effective, or it may be that the interval between the need for conservative treatment becomes shorter. And in many cases, individuals will present their horse to you for a back surgery because they believe they've got no other option. As I mentioned, we have a variety of imaging modalities which can be really very effective at helping us see what's going on in those dorsal spinous processes. And radiography is obviously one that's been used for many years, and we've been recording cases of narrowing of the interspinous space and impingement and overriding of the dorsal spinous processes for many years. But this is where we have to be really careful. We know that there is a poor correlation between radiographic changes and clinical signs. And so there's really almost no instance where we can use the changes on a radiograph to make clinical decisions. They can certainly inform clinical decisions, but they're not going to be the be-all and end-all. And we're going to want to put together our clinical signs, our response to local anaesthesia, or even treatment in helping to decide whether this is important. And that may be a particular challenge for us, particularly in cases where we're asked to examine radiographs before the purchase of a horse. We can see here the changes, and we'll come on to those classic changes in just a moment. The picture at the bottom of the slide is a gamma scintigraphy picture, and this is where we've injected the horse with some technetium 99 bound to a bisphosphonate, which is taken up by the skeleton, and more radiopharmaceutical will be absorbed in areas where there's increased metabolism of the bone. And you can see we've got this black stripe in the thoracolumbar region of this horse, which is where we've got increased radiopharmaceutical uptake. And this is a very dynamic form of imaging. This is telling us that there's active metabolism in these areas at the moment, and that can certainly help sway the decision that yes, this animal has got a back problem, which is attributable to impingement of the dorsal spinous processes, otherwise known as kissing spines. There's a variety of appearances that we might see and a variety of changes that we'll see on radiographs. If we start up here in the top corner in the withers, don't forget there's quite a lot of variation, and we've got these caps on the top of the highest point of the withers, and that's completely normal, and it will persist late into life in all horses. We've got nice gaps in between each of these dorsal spinous processes, and those gaps become a little narrower as we move caudally. But in the cases that you can see here, we've got narrowing and impingement of the dorsal spinous processes, we've got sclerosis caudally and cranially, and we've got these osseous cyst-like lesions which are evidence of remodeling and change. In some cases, the impingement will be very severe and they'll actually be overriding, and you can see there's really no space now in between these dorsal spinous processes. Clinical examination is absolutely critical, and as with all clinical decision making, trying to keep your examination very consistent from horse to horse is very, very important. You will see lots of people examining the horse's back in different ways. And of course, there are many ways to do this, but the thing to do is to pick a way and to stick with that. I like to stand on one side close in to the horse with the handler on the same side as me, and I'll use my fingers to palpate the contralateral side of the horse, moving from cranial to caudal, and then at the end palpating the sacroiliac region. It's firm finger pressure only, and understanding what's normal is important. The horse will initially dip, so it will ventroflex its back as you move through the thoracolumbar region, and then it will dorsiflex its back and its gluteal region when you get over the more caudal aspects of the back. Don't use instruments, don't use pens or biros. They will give you exaggerated responses and they're not particularly useful. And what you're looking for is subtle change to quite pronounced change. The animal may do nothing more than look round at you, maybe put its ears back, or there may be real avoidance behavior, attempts to get away from you, or even raising of back legs, muscle spasming and fasciculations. All of those things may happen. And here we have my colleague, Dr. Francina Barcelo-Oliver, examining this horse's back. So standing on one side of the horse, moving caudally, and then into the sacroiliac region, and then swapping to the other side of the horse so you can get a nice view of these fingers palpating very nicely and just moving caudally, nice finger pressure, no real pressure, and a bit of a response there, that horse responding to that lumbar area there, and then again looking back to see if that response is repeated. Lots of discussion about the use of local anesthesia, so the installation of local anesthetic solution in and around the spinous processes which may be affected by this condition. Questions to ask if you've done that are you seeing a change in response to palpation? Are you seeing a change in clinical signs? And it may be that you need to do an exercise test where the horse is ridden in front of you or perhaps lunged in front of you to look and see if that's changed things, if the avoidance behavior has gone away. The problem with it, and many workers have looked at this and discussed this in the literature, the response to local anesthesia can be a bit inconsistent. If you get a positive response, certainly it's telling you that there is some change there that may be important. But if you get a negative response, it does not rule out the condition. A little tip for you in terms of which horses really need to be treated. Let's watch this horse trotting past us. And as you can see, look at the position of that tail. So, of course, we're going to look at the horse moving away and back towards us in a straight line where we're standing behind and in front of the horse, so a classic lameness examination. But when we're examining the back, we're always going to stand at one side and have the animal trotted past us. And look again at the position of that tail. Let me show it to you in slow motion, and as this horse comes back, I want you to appreciate that this tail is really pointing out and held upwards, and it's really splinted, so it's become a continuation of the horse's back. And if you look at this back, it's not ventral and dorsiflexing to the same extent, and the tail is an extension of that back and is held in a very fixed and outward held position. And for me, that's a pathonomic change associated with pain attributable to the back, and particularly impingement of the dorsal spinous processes. As I mentioned at the beginning of this how-to guide, I will very rarely opt to perform surgery the first time we make this diagnosis of impingement of the dorsal spinous processes. Conservative therapy is really always going to be first for me, and it then becomes almost a diagnostic step of its own. Do we have an improvement to the use of conservative management? Conservative management in the first instance will be an analgesia program. We're going to break the pain cycle. And normally for me, that would be 3 weeks of non-steroidal anti-inflammatory drugs, a tapering dose as we bring the horse back into work. We're then going to medicate the apaxial musculature, and particularly that's going to be the multifidus muscle. The multifidus muscle is that bell-shaped muscle on each side of the dorsal spinous processes. It's the muscle that causes lower back pain in humans, or spasm of that muscle causes lower back pain in humans, and it's critically important in the pain response that we get in animals with impingement of the dorsal spinous processes. You will be able to medicate it very easily if you take a needle and direct it at a 45-degree angle about 4 to 5 centimeters from the midline, angling down towards the dorsal spinous process. You'll feel the needle pop through the muscle belly, and you can then medicate that area. And a variety of different treatments have been used. Most commonly, that's going to be corticosteroid medication with triamcinolone acetonide or methylprednisolone acetate. And be aware, wherever you are in the world in your jurisdiction, that there are restrictions on the use of those drugs, particularly in competition animals, and there may be withdrawal periods which can change, so don't be caught out by that. These drugs are usually made up to a volume so that they are able to be dispersed throughout the spasming muscle, and they are given carefully to make sure that we don't have complications or side effects, and I'll allow you to go away and look at that in your own time. The use of other chemicals, such as this extract from the pitcher plant known as sarapin, has also been used in this area, and also the use of mesotherapy and the use of local anesthetic solution in the same area. It's very important that we combine these conservative medications with an exercise program, just as is the case in humans. The animals that continue to work or that return to work relatively quickly have a much better long-term prognosis. And we also combine that with physical therapy, and we get that going very, very quickly. And getting your local physiotherapist on side here is a critical thing. All mammals benefit from manipulation of the musculature of the back. Having a saddle check, a useful thing to do as well, just to make sure that there hasn't been a change in the shape of the horse. And certainly the use of extracorporeal shockwave therapy has been mooted recently as another useful technique. Now let me just show you this medication, and my colleague is medicating the back here. And I don't know if you can see, but as the needle is positioned into the body of the multifidus muscle, we start to see some spasming, and you can see we're depositing some of the drug at depth, and then withdrawing the needle and depositing the drug throughout the muscle. And we're going to usually repeat that in 3 or 4 sites across the area where we're seeing the changes on our imaging. If we look carefully at this video, you can see this spasm of this fasciculation here of the musculature, and that is a very good sign that in fact your needle was positioned correctly within the body of the multifidus muscle, so something we would always look out for. So, having made a diagnosis, moved to conservative management, had a response to conservative management, and then potentially had the horse re-present after a period of time. Sometimes we might opt to manage these conservatively again before we move to surgery. But having made that decision for surgery, we're going to perform these surgeries with the animal standing and sedated. That's going to eliminate the costs and the risks of general anesthesia. And don't forget that there is a higher risk in the horse compared to the other domestic veterinary species. We're going to have reduction in hemorrhage in the standing position. We're going to usually have less movement of the musculature and the soft tissues around there. We get lots of twitching in animals that are positioned in general anesthesia, and it's a very comfortable operating position. If you're doing surgery on the horse's back with the horse in general anesthesia, and usually it's in lateral recumbency, it's very difficult to position the horse appropriately on the table, which preserves the horse's musculature and gives you a position where you can access the areas that you need to reasonably well. And if you want to review some of the early papers on standing surgery of the horse's back, then this paper by Justin Perkins, Jim Schumacher, Jer Kerry, Mary Harty, and myself then performed subtotal ostectomy of dorsal spinous processes in standing horses, was one of the early descriptions of the technique. We have two procedures that we're going to talk about prepare for back surgery in the standing horse. We're going to have an open procedure, and there's really two versions of that. We've got subtotal ostectomy of the dorsal spinous processes, where we take off the top part, the entire top part of the dorsal spinous process, or we've got a wedge ostectomy, where we take a small wedge cranially and or caudally. And then we've got the second procedure, which is the minimally invasive interspinous ligament desmotomy. And the question, of course, that everybody wants to know is, which one is the best? We'll deal with the open procedure to start with. The animal is sedated and positioned in stocks and prepared for operative surgery in routine fashion. The dorsal spinous processes and the surrounding soft tissues are desensitized by the installation of local anesthetic solution on either side of the dorsal spinous processes, which you have elected to remove, and we're putting some local anesthetic subcutaneously along the proposed incision line. As with all operating procedures, we want to be absolutely sure that we've correctly identified the area that we're going to operate on. And in the case of this removal of the dorsal spinous processes which are affected, this ostectomy procedure, we frequently will use a large gauge needle which is pushed into the dorsal spinous process once it's been identified, and then a radiograph is taken to make sure that we've got the right one identified. I like to use a 14 gauge needle, and you can use a mallet just to put that down into position. And you can see here in this case, in the radiograph, we've got our needles positioned here, then we're leaving this dorsal spinous process, going to the next but one. Again, we've got a needle positioned there, and then moving to the next but one and putting a needle there. And at that point, we know that we have identified correctly the needles that we're, the dorsal spinous processes that we're going to remove with needles, and we can then proceed to surgery. To perform the ostectomy itself, it's a team sport surgery, and you always want to have an excellent team with you in the field to really maximize the outcome for the patient. You want somebody you can trust on the head who's managing the sedation, and there will be a how-to guide on sedation for standing surgery in due course. These animals are maintained on a continuous rate infusion, a CRI, which is usually of an alpha-2 agonist, and the alpha-2 agonist of choice for me is ditomidine. And we've got multimodal analgesia here, and these animals are given non-steroidal anti-inflammatory drugs and opiates prior to the start of the procedure. We know that we need to alter the plane of sedation based on the response as we move through the procedure. And you can see here surgeons on both sides of the animal, which will really speed up the procedure. And we're always trying to reduce operative time. In standing and sedated patients, adherent drapes work very well, clearly very difficult to use towel clamps. We always position some cotton wool in the ears of the horse because we may be using motorized equipment, and we want to make sure that we don't get a big response to that. So we're really using that to augment our sedation. And because we're probably going to use motorized equipment to cut the bone, then testing that, just turning that on before you put it onto the animal, can be a good way of just gauging what sort of response. And if you're finding that you're getting a bit of response, then perhaps more sedation, and potentially you may need to top up the local anesthetic if you're getting some muscle twitching and some movement whenever you're manipulating the tissue. The skin is then incised over the affected dorsal spinous process, and the incision is extended through the skin, the subcutaneous tissue, and the supraspinous ligament. This is a very dense bit of tissue, and because it's under a lot of tension, you need to make quite a long incision in order to expose the spinous processes that you're going to be doing surgery on. As ever, you want to make plenty of space, and incisions heal from side to side, not end to end. So making a large incision will reduce your operative time and reduce the risk of complications and mistakes. The soft tissue attachments in and around the dorsal spinous processes that you're going to remove are dense and strong, and you need to spend some time breaking those down. The affected portion of the dorsal spinous process that you're removing is freed from all of the surrounding tissue using a perios elevator and, in some cases, an osteotome. And then motorized equipment, in most cases an oscillating saw, can be used to cut off the dorsal spinous process that you want to remove. In days gone by, an osteotome and mallet were used, but that's an aggressive way to do that and can cause some trauma in deeper tissues. So using cutting equipment, and there are lots of very nice systems which are available to help you do that. And that they may be air powered or they may be battery powered, and both will work extremely well. You can see here in this picture, this is the spinous process that's been left behind, and the spinous process on each side has had the cranial portion or the dorsal portion really removed nicely. And it may be that there can be some jagged or rough edges on the portion that's been removed, and they can be rounded and smooth with rongeurs and a curette. Then we have excellent lavage of the wound, and of course we would always take a radiograph just to make sure that everything looks okay where we've removed the dorsal spinous process. And you can see here we've got removal of these ones in this region here. And then we're going to lavage the wound and close the subcutaneous tissues, the supraspinous ligament and the skin. So a really nice closure, adhering to Halsted's principles of surgery, which of course are perfect anatomic tissue reconstruction. An example here of radiography before and after, and we're going to do that before the wound is closed, obviously, just to make sure that we've left no little fragments of bone, that we've got no jagged edges. And you can see here we had impingement of these dorsal spinous processes in the mid-thoracic region, and now we've removed this one here, and we've removed this one here. And that radiograph examination always performed, as I mentioned, before the wound is closed. So that's the open subtotal ostectomy of the dorsal spinous process. The only modification to that is the wedge ostectomy, where a small wedge of bone is removed cranially and or caudally. That is not a procedure which I commonly perform. We tend to see quite a florid periosteal reaction in the area where we've removed the bone, and often impingement returns really quite quickly, and it's a procedure which I think has a little or no place in the management of this condition. The second surgical procedure which I want to highlight is that described by Richard Coomer and others back in 2012, and that is the minimally invasive interspinous ligament desmotomy. And this is an elegant procedure which has really changed the way we manage these, and it's really improved equine welfare as a consequence of being able to deal with painful backs in a minimally invasive way with a rapid return to work and a high degree of success. So what are we doing in a minimally invasive division of the interspinous ligament? Well, let's just think about what we're doing to start with. In this case, we've got the yellow supraspinous ligament that we talked about in the previous procedure, but look at this orange tissue between the dorsal spinous processes. This is the interspinous ligament, which is the ligament that really binds the spinous processes together. The idea here is to try and get the back moving normally again. So by breaking down those attachments between the dorsal spinous processes, the back is able to open up again, be remobilized, and we get much more movement, and that's going to reduce or hopefully eliminate the spasm in that apaxial musculature, which we said earlier on was the cause of the pain. With this procedure, long-term success rates have been achieved with significantly reduced morbidity, with excellent rehabilitation and reduced rehabilitation time and cost compared to the traditional open surgical technique which I've just described. So if this procedure works, and let me assure you that it does, why does it work? Well, we know that myofascial pain is a common source of lower back pain in people, but unfortunately, in contrast to other species, particularly humans, the neurological supply to the connective tissue adjacent to the dorsal spinous processes in the horse is poorly defined. Some work by Derham and others describes some of that innervation, but more work is required to really understand how this area is innervated. But we don't really know what the role of that tissue is in the origin of back pain in the horse, in stark contrast to humans. But we know it's a well innervated area, and we believe that the innervation may be affected by the procedure. So the procedure purports to work by remobilizing the back, but there may be some disruption to the nerve supply to the soft tissues in this area, which may be of value. Now, one little word of warning. When we take radiographs of animals who have active spasm of the apaxial musculature, we will see overriding and impingement of the dorsal spinous processes. When we anesthetize these animals, or when we put some local anesthetic into these areas, what we'll see is a reduction in the spasm, which seems to lead to less impingement. So these spaces open up again. So there can be changes, and those radiographic appearances are affected by absolutely sedation, anesthesia, analgesia, and physiotherapy. So suggesting that the back is not mobile when the horse is affected by impingement of the dorsal spinous processes is a slightly oversimplistic interpretation of what's going on. And as I say, it's a poorly understood area. So hopefully there'll be some studies in the near future really looking closely at the soft tissues and the innervation to this area. So moving to the procedure itself, the animal is again restrained in standing stocks, and the animal is prepared for surgery in routine fashion. The surgical sites are again identified radiographically, and the areas are desensitized by instilling local anesthetic solution along the track of the instrument. You can see the horse is standing in stocks there, and the X-ray machine is in position ready to radiograph this animal. Initially, we're going to place a spinal needle into the interspinous space, into the areas where we've got impingement. And I like to use a 20 gauge spinal needle and carefully position that, as you can see in this bottom picture here. So we've got these spinal needles which are all nicely positioned in the interspinous space. Once we've placed these, we take a radiograph to make sure that we've got our needles in the correct position, and then we are going to place local anesthetic along the track of our incision. So we're going to go from a paramedian position across the midline, placing local anesthetic along the track of where our instruments are going to go. We make a 1 centimeter paramedian incision, and then using a large straight Mayo scissors, push that through the thoracolumbar fascia into the interspinous space, and then open up the scissors. And the idea of that is that the scissors are opened to break down the interspinous ligament over a distance of 5 to 7 centimeters. Some of those spaces where there is very marked impingement and the space is almost obliterated may not be amenable to the scissors moving into that space, and in those cases we use a small osteotome. These incisions are closed in a single layer with interrupted sutures. Now, to see the procedure, this is the local anesthetic being instilled. So we've got our needles in position. We place our needle across the track of the incision, and we're going to instill some local anesthetic. And again, you can see the operator is pulling their needle back as they place the local along the track of the incision, and then leaving a bleb of local under the skin at the point where we're going to make our skin incision. And then moving to the next site, we can then again see where we're going to incise, drive our needle across the interspinous space, and again connect our syringe with mepivacaine solution or 2% lidocaine solution, and then we're going to instill that into the track of the instrument. The procedure itself, very straightforward. Make a 1 to 1.5 centimeter skin incision, which is going to extend through the skin and into the subcutaneous tissue. At this point, we would use our straight Mayo scissors, and we're going to drive those into the thoracolumbar fascia and into the interspinous space. Often you can see the needle moving there. We know we're in the right place. We can then push that into the space. Sometimes you need to manipulate those scissors to some extent to get them to where you need to get them. Then we're going to push them a little to try and see, can we get them into the space that we want to get them into. Now, in a case like this, and this is quite common, we're not really able to move this to where we want it to go. We need just to push a little bit, but we may need to switch then to our little osteotome. So we've got this narrow 0.5 centimeter diameter osteotome, which we can then push into interspinous space, going down the track that we've already created with our Mayo scissors. I never like to use a mallet, so I'm always just using manual. Take the needle out and then push this across, and then this will move nicely into the space and allow us to break down the interspinous ligament between the affected dorsal spinous processes. At the end of the procedure, having performed the interspinous ligament desmotomy on all of the affected spaces, the skin is closed in one layer using interrupted sutures, and an adhesive dressing is placed. We like to use Polsterplast, and we keep that covered, changing it every 2 to 3 days until the point of suture removal at 10 to 14 days. Can't emphasize enough that instruments here are critical, so not a curved Mayos, but a straight Mayos, and the small osteotome. This was a modification of the procedure, which many people use, is a really critical thing for success. For aftercare, for the open procedure, these animals have 5 to 7 days of non-steroidal anti-inflammatory drugs. They're kept in a box for 2 weeks and then a small paddock for a further 4 weeks, and then they have a further 6 weeks of paddock rest before they recommence exercise at around 3 months, and that's just because of the large incision. Contrast that with the minimally invasive procedure, similar 5 to 7 days non-steroidals, but a very short period of box or paddock rest, 2 weeks, then 2 weeks of non-ridden exercise, building up, and then they're commencing ridden exercise again around 3 to 4 weeks after surgery. These animals are back in work very quickly. You cannot ignore rehabilitation. It's absolutely critical to success. These animals should be returned to work to some kind of exercise as soon as they can be. They all need physiotherapy, and in my view, that should continue for the rest of their life. Horses that still have clinical signs after these procedures have the wrong diagnosis, or perhaps have more sites that require desmotomy. And what of the outcome? Well, the outcome's not bad for both procedures, but you can see for the minimally invasive procedure, we're expecting a good result in around 95% of horses. A couple of lovely papers looking at the long-term prognosis and looking at the effects of these procedures in performance horses, one by Prisk and others from 2019, and one by Derham and others in 2019 also, with a large number of horses. So really good papers that you can have a look at to give you an idea of the outcome and the success, and what prognostic factors might be useful in making the decision for surgery. So which procedure is best? Well, the answer is that they're used for different problems. They both have a place. The pathology is diverse, and so are the clinical signs. And if you've got loss of the interspinous space and severe overriding, you're always going to have to perform an open procedure. Case selection is absolutely critical. Imaging is absolutely critical. And these two procedures really treat different pathology. And it may be that in some cases you might even combine these procedures. So if you've got severe overriding and new bone formation, you would elect to remove do the ostectomy procedure, but there may be other areas where you've got impingement but no overriding, where you can move to the minimally invasive procedure. So the severity of the pathology dictates the approach. You can see here in these skeletal specimens, we've got impingement, we've got in fact overriding, and these spinous processes are stuck together. This is how that might look on a radiograph. There's no question that this is an animal which is not going to be a candidate for an interspinous ligament desmotomy. It might even be a challenging candidate for an ostectomy. So it would be unfair not to say that there are some animals that we really can't fix without, we can't fix with a surgery. These animals have widespread pathology, so lots of impinging processes, as you can see in this middle radiograph here. And I think it's just useful to say before we finish that conservative therapy is always worth considering. We've got publications which suggest that we can get a good response to conservative management. You will almost certainly need to repeat it. And I'll just add in here that the use of bisphosphonates, and there are other bisphosphonates available other than the one shown here, have been extremely useful in the treatment of pain attributable to impingement of the dorsal spinous processes. This horse here was a racehorse here in Scotland for many years with really pretty severe changes across his back, and he was managed entirely conservatively and had really quite a long career, a long, very successful career. So don't be caught out by getting blinded by the radiographic changes if they're severe. It's always worth considering conservative management. Some horses will cope very well with that, albeit that you'd have to repeat it. But don't just take it from me. Here is my great friend, Scottish champion trainer, Mr. Jim Goldie, talking about the effect of this procedure in allowing horses to return to high-end performance.
Get into your bar. That's how he described it. He's just shaking like this. Just the thought of running in the race. That's how bad it was. He's into the stall. Now he's a lot happy. He's like an alcoholic that hasn't had a drink for a fortnight. Get into your bar. That's how he described him. He's just shaking like this. Just the thought of running in the race. That's how bad it was. And now he's a lot happy.
So what's the take-home message? These are very good procedures. The interspinous ligament desmotomy has changed the welfare of horses, and not just racehorses. This is a procedure which we perform regularly on horses of all sorts of use. There's no need for an animal to go around with a sore back, because we can make the interventions which will allow this animal to have a pain-free existence, and that's really what we're looking to do. Thank you for taking the time to listen to this veterinary high performance how-to guide. The information presented here is for illustrative purposes and is based on our views and opinions only, and not the opinions of anyone we may work or have worked for in any context. This series is not intended to provide direct veterinary advice, and if you're faced with an injured animal or a sick animal, you should seek the advice of a veterinary professional in your jurisdiction. If you've enjoyed the material presented here or any of the other bits of information presented on the Veterinary High Performance site, please consider sharing this on your network or subscribing to Veterinary High Performance. Thanks for your time.